Hello, everyone, and thank you for joining us. This is Zena Dott with JBS International. And before we begin today's session, I'd like to review some housekeeping items. Please note all audio connections are muted at this time, and we ask that you please keep your lines muted for the duration of this session. If you have any questions or comments, please submit them by using the chat feature located at the bottom center of your Zoom window. Questions will be addressed during the Q&A segment at the end of the presentation. If you experience any technical issues during this session, please message the host using the chat feature. Lastly, this is a recorded event and your participation grants consent to be recorded. The recording of this session and PowerPoint slides will be available and sent to participants at a later date. And now I'll turn it over to the moderator who will introduce our speaker.
Hi, everybody. This is John Roberts with JBS International. I'd like to introduce Jim Sacco. Jim's an LCSW and a trainer and consultant based in Asheville, North Carolina. As a clinical social worker, he's worked with clients with SUDs and worked in mental health, medical, and community settings. He provides training and consultation to a wide range of academic, governmental, and community-based organizations throughout the Southeast and now throughout the West. His former clients include the World Health Organization, the U.S. Centers for Disease Control and Prevention, Emory University, Duke University, Vanderbilt University, and state and local health departments across the Southeast. Jim has trained more than 50,000 healthcare workers since 1986. And Jim, I'll turn it over to you.
That's great, John. Thank you. Hi, everybody. So I want to shout out to people who already said hello. Caitlin Moore, Olympia, Washington. I've been there. Wet and lovely is my memory. Hey, Liberty, nice to see you. Hey, Michelle, also from Oregon. Where's Michelle from? Somewhere in Oregon. Anyway, what I've said, folks, if you have a chance in the chat, Michelle from Rochester, New York. Well, there you go with RCORP. I'm glad that you're here. And La Grande, Oregon. So everybody who's willing, I'm monitoring the Zoom chat. John's helping me. So go into the Zoom chat, the bar down at the bottom of your screen. Click on chat and then select everyone, and we'll have a chance to say hi to one another. It's a small enough group. We're not going to hold Q&A till the end. So as questions arise, if I'm saying something you're curious about or want to know more about, John's watching the chat as well, but please feel free to jump in the chat. And again, if you haven't had a chance, please get in the chat box and say hi to your peers. Tell us where you work and where you're from. So as John said, I'm Jim Sacco. I'm a clinical social worker who stumbled into public health, and I make my living, well, I was going to say usually on the road in a conference training room, but for the last year I've been in my basement. We've got a nice sunny day in Asheville, so I came up to the kitchen. I was like, we've had a cold, wet winter, and so I was like, I'm going to enjoy the sunshine. So I'm delighted that people have made time for this. We're going to spend 75, 90 minutes talking about integrating health promotion and what this is code for. If you did read the description, my experience, and I want to own this as my experience. My experience when I look back on my career is I'd be working with people in one area and sort of thinking about just that area. And looking back, I think, wow, I missed a chance to, for instance, not talk about sexually transmitted diseases, people that I knew had, active substance use disorder, active opiate use, but I wasn't saying how you're doing in terms of your sexual health or pregnancy planning, or working with people that inject and aren't taking steps or thinking about screening for hepatitis or getting vaccinated for hepatitis. So the impetus for this talk is really my own clinical practice, where I look back and say, man, there were opportunities for me to work with people around some important health issues that I missed just because it wasn't on my radar at that time. And so the hope I have is to challenge people, not in a bad way, but to sort of begin a conversation in this webinar. How are you doing at meeting all the needs of people that you serve in terms of their sexual health, prevention of infectious disease, and taking a sort of holistic response? I'm also clear that it may not be in everybody's scope of practice. I suspect many of you are accountability dependency counselors or social workers or licensed counselors. It's not in the scope of your work to implant IUDs, and so I'm not saying please everybody start implanting IUDs. I think there's a scope of practice question. And I want to also acknowledge there's a time constraint. There's most of us have priority things that we're focused on. You have to triage with this client what's the most important thing to talk about, to focus on today. And with many clients, there's also the issue of how much time they've got for whatever we're offering. So within the constraints of your scope of practice and whatever else, what I'm doing is challenging you to think about what other health concerns you might be addressing. And again, I hope this is a start. I hope you go back to your staff meeting, go back and talk to your colleagues and say, hey, I was at this great regional meeting, handsome bald guy from North Carolina. Please say it that way. Handsome bald guy from North Carolina ask these questions. How are we doing at preventing STIs? How are we doing at talking about pregnancy intention? What do we know about HIV prevention? And how are we doing at collaborating with people? Part of what I'm clear about is if you're not the place to administer hepatitis vaccination, then what about making sure you've got memoranda of agreement with people who do have that service available, and you can link people. So it's not even a question of you must, in my opinion, you should do all these things in-house. But when I think about a kind of holistic response, it's kind of, here's what you do, but you've established relationships with a number of people, formal relationships I think are best, where who can offer additional services to things your consumers with opiate use disorder might need. Welcome to those of you who've joined us. I'm Jim Sacco. A few people have joined since I started. Let me just invite people, if you're willing, in the chat bar, in the Zoom chat bar. So the black bar, the bottom of your screen, if you scroll over to find chat, get in the chat box. I've asked people to introduce themselves and say hello, tell us where you are and where you work. And also I want to use that as the meeting progresses. So the black bar, scroll over on the far right and click on chat, pull everyone down, and I'll be monitoring that for questions and hopefully having a bit of dialogue today as we move forward. So those are the objectives, that's the goal. And I guess what I'd like to do is talk about sort of what the ideal model for integration might look like. And again, here's where I say, I realize I don't think many opiate use disorder places are currently doing all this, and many don't have the capacity to do all this. But when I think about what a comprehensive approach might look like, what I think about is that the ability to talk about sexual health is encouraged. One of the things I think about, and I was trained in, oh, thanks for typing in. Hey, there's Megan. Hey, there's Jen. Everybody who's willing, where are you? And where do you practice? So, in social work school 100,000 years ago, if I had 5 minutes of sexual health, it would be a miracle. Nobody told me how to talk about this. So I didn't know what to do. And I think we're all kind of self-taught, but I think about what an important part of people's lives we miss if we don't say, this is a place where we can talk about your sexuality, your sexual health, and have that opportunity. So discussion of sexual topics is actively encouraged. Sexual health information is freely shared. I'm talking about more than pamphlets on a rack here. I know that's the easiest. You can check off for HRSA. Oh yeah, we got pamphlets on a rack. I do think that there's something for a number of people about sharing what we know. And again, I'm not saying all of us need to know everything about sexual health, but I really do think that sort of having some ability to handle common sexual health concerns ought to be part of our collaboration. Hi, Tanisha. Hi, Shelley. Hi, Jolynn. Everybody, thanks for doing the introductions in the chat. Hey. Pregnancy intention is assessed. What we'll talk about. I'm doing this quickly because this is the outline for the rest of the talk. Do you want to have kids or not? Pregnancy intention is assessed. There are a lot of implications about the importance of planning, of avoiding all kinds of prenatal problems. If mom is still using, finding the right opiate replacement. If mama does intend to get pregnant. So do you plan to get pregnant? And what do you know about getting pregnancy? Hey, Melinda. Phoenix, Arizona. I got a good buddy visiting Phoenix right now. Eric is from South Central Colorado. Great. Thank you, Eric Stevens. Risk assessment is conducted as appropriate. You may not have to ask everyone about number of partners and what fluids and who they inject with. You know, I do think that for some people, again, they need more than a pamphlet on the rack, and for us to have really intimate discussions about who you shoot with, who you share with. And then where it's appropriate, some counseling about how to reduce risk. Hey, Gabby. Man, Gabby, I'd try your last name, but I think we'd be here all afternoon. I'm just going to call you Gabby, the evaluator in Utah. Hey, Gabby. HIV testing and screening. You know, part of what we know is there's 40,000 people newly diagnosed with HIV, more than 40,000 people, new HIV cases. I think some of those people are sitting in our waiting room. If you're in the opiate use disorder business, I think you've got people that haven't been screened that probably are HIV positive. And certainly you've got people, if they're actively sharing needles, who are absolutely at risk. So are you screening, testing, having conversations about HIV prevention? Again, making that connection between substance use disorder, opiate use, and hepatitis. I mean, the other bad news is you know, we see an increase in hepatitis A all over the country. Certainly started pockets of my friends in Seattle can tell us, Seattle, San Diego, big Hep A outbreaks in the last couple of years. I think Denver had and recovered from a Hep A outbreak, definitely linked to homelessness and definitely linked to drug injection. And so again, sort of having conversations about hepatitis prevention ought to be part of this. And then referrals. Again, I recognize most people doing opiate use disorder treatment aren't providing post-exposure, pre-exposure prophylaxis, I'll define these shortly, and STD treatment, but that we've got relationships with primary care providers, healthcare providers that can meet those specific medical needs. So again, not to overwhelm anybody, say everybody has to do all those 10 things. You know, I do think print this off and have conversations with your colleagues when you get back to the office. Hey, which of these things do our patients need now that we're not providing? And do we write a grant to expand what we do? Do we have the resources now to expand what we do? Or do we expand our network and find people that can meet these unmet needs? That's the challenge today. That's the question. So thanks again to everybody typing in. I wanted you to type in to meet you, and I wanted to begin this with a discussion. So for those who haven't joined us yet, in the chat box, you go down to the Zoom chat, not the Whova chat at the top, down at the bottom, the Zoom chat, the black control bar far right, you'll get to the chat. Open that chat window up, and let's talk about barriers. What makes it difficult to do all the things I just talked about? So if we're doing sexual health integration, we're doing all those things, and I would be foolish if I said that was easy to do. So I want to start by talking about barriers, and what I'd like to do in our chat box is begin to think about what the barriers are in 3 different ways. And I'll start with the first question. What barriers, I'm going to type it in, do consumers face in this task? So in other words, if you think about, for a typical consumer coming in for opiate use disorder services, what barriers would they bring that might get in the way of integration? Michelle Herman starts us off: stigma. You better believe it. Stigma of having opiate use disorder, stigma of going to see you, stigma of talking about sex, stigma of talking about sex partners. Absolutely. These are uncomfortable conversations. Tanisha says transportation, insurance. Absolutely. As a consumer, I can't get to the places I need to go. And one thing I know about the Western US, it's one thing to live downtown Denver, downtown Seattle. But if we're talking about, I live in South Central Colorado, and I'm trying to get transportation to the nearest place to get clean needles or get sexual health consultation, I may have quite a pony ride down there in South Central. Eric, I hope you don't mind talking about ponies down there in South Central Colorado. 8,000 square miles, no public transport. That's a long horse ride. I'm not even a horse guy, but I can tell you 8,000 miles to get an STD test is a long ride. Caitlin Moore says fear of telling partners. You bet, because they were asking these questions. Some part of this is go back and tell your partners. If we're asking about pregnancy intention, do you want to get pregnant? We're talking about How does your partner feel about it? What do you think your partner's going to say to HIV prevention using condoms, or a partner's going to say to are postponing pregnancy? Or maybe partners ready to have kids. He maybe think it's a great idea. Second question, let's go to that middle box. If you were to think about barriers for us as providers, what makes it hard to do all those great things on the previous slide in terms of our issues as frontline opiate use disorder providers? What barriers do we providers bring to sexual health integration? Michelle says, I ain't got staff. That's what I'm talking about, time and staff. Well, you guys are on the same page. Time, staff, we're doing all we can. Funding, quality staff. Thank you, Eric. Yeah, I mean, that's what he said. I didn't feel like I could say everybody's supposed to add all those 10 things, because everybody I know doesn't have enough time in the day. It's just barely doing what they can. And so do we have the time? Do we have the right personnel? Eric says, what about quality staffing and the money to do that? So do we have the funding to support that? And what about staff? And Jen Rolfs, I think, asks the first question, which is how comfortable are we? And I think most people I know maybe have gotten comfortable with hepatitis conversations, maybe have gotten comfortable with needle use, but sort of, I think for most people, there's a stopping point. Most people I know, and again, no criticism. I think excellence in doing this means asking yourself, can we build our staff capacity, push our staff past the capacity, current capacity, to learn new things? Or do we make a referral network to have other people who are funded, who do have staff with that expertise to do that for us, to collaborate with us? Last barrier I said I wanted to talk about was about system issues. And here I'm talking about the board of directors. Yeah, Jen says, what about how our beliefs create stigma? Absolutely. Those people kind of barriers and discomfort. Thank you, Jen. Last question for all of us. What are the system level barriers, sort of for administrators, for boards of directors, for people at the sort of highest level of the organization? What are the barriers from the perspective of your administrators, again, of your board, of your funders? What are the sort of organizational barriers to doing this thing? Frontline boards out of touch with the need, don't understand the importance, legislative constraints. Thank you, Michelle. Eric's is being overwhelmed. The executive directors already got 3 jobs and running a part-time needle exchange out of their trunk, most of them. What can they do? And Jen says, what about the mission? Absolutely. I'm also thinking some of this pushes us to where there might be public relations problems. And I just want to clinic welcome and open to address sexual minority, sexual gender minority persons. Lots of initials there. Thank you, Megan Price Gomez. Is the clinic welcome and opening? Absolutely. And are we willing to do that? Charlotte says it's not our job. And again, yeah, Charlotte, I mean, that's not a criticism. Sometimes it's the funder, sometimes it's training, but really, if you print that list on the previous slide and show your boss, say, hey, this bald guy says we ought to do all these things, some bosses are going to say, that's a terrible webinar, and they ought to fire the JBS, ought to fire that bald guy because he don't know what he's talking about, right? I mean, that's it's a tough leap, and the potential for systems to get into trouble and to get some bad press, and do we want to talk about that, and do we want to be in that business, and scope of practice issues for systems is another barrier. So I don't want to be pessimistic, but I do want to be realistic. And as you begin these conversations with your peers, with your staff, to kind of acknowledge those barriers are real, and that any implementation plan to sort of expand what you do or create networks to better serve your clients' needs have to address those barriers, have to say, to be realistic. So one thing we all have control over is kind of our one-on-one conversations. I can't control funding, and nobody at HRSA asked me what I think they ought to do. So in fact, nobody at JBS asked me what I think we ought to do. So there you have it. What I do think is compelling is to kind of think through kind of what we do one-on-one. I go back to the clinical one-on-one, and one of the things I do in terms of the issues of training is just in training. I like to just say, let's just talk about opening the door. And again, at my heart, I believe in clients leading us where they need to go if we begin the conversation. And so one of the things I do is offer a model. There's not one model, but just sort of tell people while we're talking about sexual health and pregnancy intention, in order to keep you healthy, in order to address your whole health, your whole self, I invite, again, making the approach universal. We ask everybody. We have a set of questions we ask everybody in order to help them stay healthy, right? We're about health. And so I want to acknowledge there's some personal questions. I'm going to ask you some personal things, and what's said between us stays between us. This is not something that I need to share with anybody outside our conversation, but so that I can help you, I'm going to ask, some things about what you've done when you've been drunk or high. And I hope you'll feel comfortable talking to me about that. I want to talk a little bit about, where you've been in terms of previous risk exposure, those kinds of things, so that I can help you. Our conversations remain confidential. And I really like giving people an out. I just think there's something deeply respectful about saying you're in control of how much information you share. I just think at the start of any history gathering, you say, you know what, you tell me as much as you want. So you just figure out good open-ended questions, who, what questions, where, when, say, tell me about, say more about. And I think what's also important as we start to think about these good open-ended questions, to not approach this without really thinking through our language, and particularly there down at the bottom, some cautions about sexual orientation, forms that say, or I see John Roberts, I say, well, John, do you have a wife or a girlfriend? Well, I don't know what John Roberts is up to. John likely has boyfriend and girlfriend. Right? You wouldn't mind me sharing that, John, I wouldn't think. So language that isn't inclusive around sexual orientation, gender identity. I mean, more and more, I think forms that say male, female, or both. I think to have conversations that say, we see people who define as male, female, transgender, non-conforming. What's that like for you? To just find open-ended questions to invite people to talk about their gender identity. Someone says, I'm in a relationship. Oh, I'm in a relationship. Oh, good. I don't have to talk about sex at all. Well, I think there's a real argument about asking everybody, regardless of monogamy, about their sexual health, to not assume that married, coupled, partnered means I only have one sex partner. And certainly not that there's only one person I'm sharing needles with. So what values about sex? What about values about fantasies? Perception of what sex is and isn't. Again, our language, to really kind of take our time and be really mindful so that our language doesn't unconsciously injure somebody who may have a different value about sex or fantasies than we do, who may have different ideas about what sex is and isn't. One of the classic what sex is and isn't, I've done a lot of teen pregnancy prevention work in my day. And one thing I know is, there's a thing where a lot of kids think, well, as long as I don't have penile-vaginal intercourse, as long as there's no penis inside my vagina, right? That's not sex. And so people would say, oh, hey, 16-year-old kid, are you having sex? No, we're not having sex. We're not having sex. Okay. And they get to check, oh, still absent or whatever. And then, you pull them aside and say, well, is a penis ever inside your mouth? Well, yeah, heck yeah. Is a mouth ever inside your vagina? Well, heck yeah, daily, and then you go, well, what, and what about penis inside your anus? Oh yeah, well, we love that, but it's just that sort of sex only means penile-vaginal sex, for some adolescents. And so there's an example where, you having sex or not really makes some assumptions that isn't going to give you information that you need to, in that case, to really prevent disease. I mean, you're avoiding penile-vaginal intercourse allows, make sure there's no pregnancy. But in terms of STIs, I mean, that's the context that comes to my mind, having done a lot of HIV work and knowing how effective HIV is transmitted through anal sex. It's like these kids are saying, oh, I don't really have sex. And then you dig deeper, but oh yeah, my boyfriend and I love to do anal sex. It's like, that's really concerning. So let's do a quick poll here. Everybody jump in the chat box. Those of you who joined us, we are chatting in the Zoom chat down at the bottom. Zoom chat. There's your question. Your clients, I'm asking for really the people talk about their clinical practice. Both male and female, now this is everybody you see, are actively planning around pregnancy. So in other words, they're consciously saying, I am going to have a baby, and so I'm doing the things I need to do that. Or I'm not ready to have a baby, so I'm taking steps to not do that. That's what I call active and conscious planning. What % of your consumers on your caseload, current consumers of your organization, give me a percentage who are consciously planning around pregnancy? Go ahead, somebody give me, I'm looking in the chat box, what % of your current, let me see, hang on, let me go back. Charlotte says, good heavens, less than 15%. Oh, Charlotte, that is very depressing news. Jolynn says, no idea, but it can't be good, Jolynn, eh? Jolynn is saying it's not good. Anybody else? What % of male and female patients are saying, yes, I want to have a baby, and here's what I do, or no, I don't want to, and I'm taking conscious steps, conscious, active planning about pregnancy? Somebody else, give me a number. I'm looking for a couple more people to respond in Zoom chat. John Roberts, do you have Whova chat, or we're just in Zoom chat? Is that right?
Just Zoom chat would be best. Yes, we're having some issues with the Whova chat. So if you can do the Zoom chat, that would be best. Yeah.
Go down in the black control panel. Anybody else want to venture a guess? Caitlin says not working directly. I knew some people weren't, Caitlin. Thank you for that. Anybody else? Well, let me tell you what's going on nationally. There we have it. Nationally, we are talking about what my data is. Hang on one second, I gotta get. My data is, my data is 2017 data, nearly half, 45% were unintended of that. And so this is just of the general population. So almost every other pregnancy is unintended. Of that, about a quarter, 27%, yeah, we want a baby later. Almost 20%, 18% say, oh no, we don't want no baby. And yet there were more than 6 million pregnancies. Highest among low-income women, younger women, cohabitating women, women of color, and lowest unintended pregnancy rates among higher educated white college graduates and married women. Nearly 40% of unintended pregnancies end in abortion, 60% ended in birth. So of those 2.8 million, about 40% of those patients chose to terminate the pregnancy, and about 60% went to full term. So that's the overall picture. Let me bring it down to opiate use disorder. This ought to wake us all up. Among people with opiate use disorder, 9 in 10 nearly 9 in 10 were this is a meta-analysis article, 2016 meta-analysis article that sort of looked at a number of studies about unintended pregnancy with people that have opiate use disorder. 86% were unintended, not timed right, I wasn't ready, 34%, I didn't want no baby, 27%, I don't know if I want a baby or not, 26%. What strikes me about this, having worked with so many people, I'm just going to say so many people whose parents clearly weren't ready to have children, weren't effective parents, weren't ready to have the responsibility of being a parent. I look at this, I go, oh man, what does that say? The timing's wrong. I don't really want this baby. I'm ambivalent about having a baby. And what happens? I mean, certainly some of those people rise to the occasion, become good parents. I would argue a bunch of those parents create the next generation of kids with trouble. So regardless of pregnancy intention, 90% of the sample had a history of drug abuse treatment, average more than 3 times in treatment. So here's the wake-up call to all of us. Of those unintended pregnancies among people with opiate use disorder, 90% have been in treatment somewhere. So again, why am I challenging people to talk about pregnancy? Well, a whole bunch of people have been in treatment somewhere before they had an unintended pregnancy for their opiate use disorder. And again, this is where I say, well, they're there. 34% are going to time it wrong. 27% are getting pregnant, not want it. Another 26%, whole, but not 86% unintended. Maybe in drug treatment settings, we should say, if you don't want to have a baby, we've got super duper ways to avoid having a baby until you're ready and the baby is planned. So condoms are the highest form of lifetime contraception in this study. 69% had used hormonal injections, particularly Depo-Provera, the every 90-day injection. 40%. IUDs were third. So unfortunately, the most effective method of birth control, long-acting reversible, that is implants, little matchstick implanted, or IUDs, or Depo-Provera shots. Those are the three that are long-acting and reversible, especially implants and IUDs have the lowest use. So again, people who were had opiate use disorder in this study had the lowest use of the most effective methods. They're using condoms when they can think about it, when they got their wits about them. Again, IUDs and implants are really ideal for people whose lives are kind of chaotic, who do better with a kind of set it and forget it mode, but unfortunately not well used. So a long-acting again, I've got no economic investment in anything, but in terms of effectiveness, there's nothing like implants, IUD. Hormonal contraception, pill, patch, ring. Everybody knows about the birth control pill, patch. You put a patch on weekly. A new ring is inserted weekly, or Depo-Provera, the hormone injection. Barrier methods, male and female condoms. EC is emergency contraception, available most places to adults. Yes, most places to adults over the counter without prescription, although different pharmacies, different state policies. I'll put that in the chat box. Is emergency contraception available where you live? Tell us your state and where you live. If people don't mind, I'm curious. I think most places. And permanent contraception. Let's see. Ryan said, I'm sorry, I missed this chat, Ryan. Ryan says, actively doing something 30 or 40. So great. So Ryan, you're ahead of the game, brother. We got Ryan's practice is asking about pregnancy intention, and 30-40% are doing something about it. So 30-40% or less. I got a study that says 90%, Ryan. So you're way better. And poor Jen is a lowly data analyst. Jen, they could not do it without you at report time, I'll tell you that. So what do we do about helping with pregnancy intention? Again, this may not be all within the scope of everybody's practice, but what Ryan has modeled for us in this webinar is, hey, what's your knowledge about reproduction? I'm asking about pregnancy intention. Do you want to get pregnant or not? If you didn't do anything other than that, and then we're going to refer people to help you figure out a method and talk about benefits and barriers, then I'm going to give you an A+. If you could just screen for basic knowledge, ask about pregnancy intention, and make referral. The great news is, for these concerns, for sexual health concerns, some money trickles down to most county health departments to help with low-income people getting on methods, and so all this can happen. I mean, I think if you're a medical site and you're doing some medical stuff, you may say, hey, these people are already here. The problem with people who have opiate use disorder, in my opinion, is getting them to, even in urban areas where there's an active subway system and they just have to take the next subway stop, we're going to lose people. And poor Eric is saying, I got to put people in a buggy and have the buggy go 7,000 miles across southern Colorado to get to an IUD. It's a whole lot of trouble I can get into between here, your clinic, and the place that's going to give me a method of birth control. So in some places, it may be pragmatic to say, you know what, given where we are And given the need, maybe we need to figure out how to train one of our nurses. I'm just saying. So next question is about HIV. One of the questions I asked up front was, how are we doing at HIV prevention? And so same thing. And I hope some of you are asking about HIV. So what steps, what percent of your consumers, what percent of your current clients, even my lowly data analyst, you're analyzing the data, Jen. So of the people in treatment, what percent of consumers do you suppose, you can give me a guess, do you suppose are thinking about HIV and taking steps to lower their risk of HIV? Oh, Ryan Jackman says they're prescribing contraception afterwards. If only I could place IUD right. Yes, condoms in the clinic. Yeah, Ryan, I wish you could place IUDs or either implants. If you've got the clinical staff, drug companies are going to help you work with. Drug companies are going to help you with insertion training. So private message me, or I'll give you my email, Ryan, if you want to talk more about that. So what percent of people are thinking about HIV risk? Megan says less than 30%. Anybody else? What percent of your consumers are saying, wow, I'm concerned about HIV and I'm taking steps? Give me a percentage of your clients, current clients, who are taking steps. Anybody else? Give me an estimate of the number. Ooh, Molly. 10%. That's depressing, Molly, but I mean, it's not, right? It is what it is. Anybody else? What percent of your current patients said, hey, I better be worried about HIV in my hair, shooting, having sex with people, sex for money, sex for drugs? I better be concerned. Not enough. Sounds like the answer is not enough. So what I'll do is tell you what the federal government hopes of all of us, including our good friends at HRSA, our partners in this, the National HIV/AIDS Strategy, HRSA, CDC, NIH have come together. Ryan says drug injectors are more cognizant. So Ryan says, if I've been injecting people who've been injecting people who have participating in needle exchange have more of an awareness. I'm in the needle exchange because I'm aware of something. And so there's a logical link. But Ryan says of the total, maybe 20% are thinking HIV. And again, that's not super surprising. Charlotte says, oh, great. So Charlotte, same thing. So where we've got an active harm reduction needle exchange, people are thinking about that. And yeah, Charlotte, excellent. Very low HIV positivity rate. That's not uncommon. In the non-urban Western United States, that is not uncommon. And Charlotte, everybody on the webinar, I look at what's happening along the Appalachian Trail, and I think pay attention to opiate use disorder along and prescription drug misuse, and where prescription drug misuse leads into injecting prescription drugs and or leads into heroin use. And so I think many of you are lucky that there's a low HIV positivity rate. And I think about Scott County, Indiana, 5 years ago, 18 months ago, we had a significant outbreak in West Virginia, again, a place that had fairly low prevalence, lots of opiate use, but not a high. I guess what I'm saying for everybody who's part of this webinar, given the population you work at, to monitor drug use trends and to be really aware of changes in drug use trends, especially when injection starts, and watch those injectors, because the potential for a kind of rapid outbreaks. And I guess the other challenge is all of you guys are in a position where if you're working with drug injectors, you're in a position to collaborate with your state health department, with your local health departments. If there's a little outbreak, your health department is currently at work. All state health departments are asked to think about, if there's a little outbreak among drug injectors, how can everybody respond quickly so that that little outbreak response, the response to that little outbreak prevents a much larger response. So pay attention to, stay aware of those little HIV outbreaks and be prepared to respond as part of a community-wide effort would be my advice. So AIDS strategy says, let's get people tested and link them to care. Full exposure to exposure prophylaxis. That's PrEP. That means I take one pill once a day to prevent HIV, even though I haven't changed my sexual or injecting behavior. So one pill once a day, 99% effective. We have two medications. I'll show you in a minute. Two medications currently authorized. Access to syringes. We've got several people here who are running syringe service programs. Excellent. And again, where there are access to needles, we see HIV rates, hepatitis rates dropping to zero. Support for people living with HIV. Good medical treatment for people living with HIV. And again, to full disclosure, we talk about HIV in this country. We really are talking about 26. The efforts of the government are focused on 26 largest urban areas and the southeastern United States, and really not in the rural West. I don't want to give you a pass, and certainly when we talk about unintended pregnancy, hepatitis, STIs, there are other issues. In terms of HIV prevalence, somebody said we're in a low prevalence spot. Most of the Western United States, outside of Denver, Seattle, San Diego, Los Angeles, fairly low prevalence. Certainly the frontier states, not much. So the government priorities are figure out who doesn't know their HIV status. And again, the nice thing about this is it's not a big leap for you. Many of you work with people who work near people who are funded to do HIV testing. I'm thinking of HIV service providers, of county health departments. They're receiving funding to do testing, and their charge is, hey, find people who don't know their status. If you've had people with a history of injection for any period of time, you might engage them in HIV testing. There are other interventions, social network strategies, an intervention, really interesting intervention. If you think about opiate use disorder, you identify one member of a drug using network, and you work of a syringe sharing network, and you work with that person to identify previous partners, to refer previous partners to be HIV tested. So you find the right index patient, they are given incentive, and their partners are given incentive to come in and get HIV tested with sexual partners, or as it relates to the topic here. And so the questions I'll put forward sort of, what about testing in medication assisted treatment? What about testing in SSPs? Yeah, thank you, Ryan. And that's why I say these conversations, Ryan in the chat box, excellent, says we're in a low prevalence HIV place, so it's off people's radar. And that's exactly true. But what about higher incidence of hepatitis C? And absolutely, I get concerned when people say, oh, the Western US outside of, 4 or 5 cities, and Texas, large cities in Texas, another story. But the real Western US outside of 5 or 6 big cities don't have much trouble, and you think about, well, maybe now, but what about hepatitis? What about the risk? And again, particularly, as I said, there are all kinds of stories along the Appalachian Trail of these smaller towns, never dreamed they'd have HIV, had a lot of opiate use disorder, and these kind of outbreaks. And so I think, it does make sense to say, how much time do we spend on HIV testing? But it is, to me, it's part of a conversation about HIV, hepatitis, sexually transmitted diseases, and prevention, and pregnancy prevention. Like there's just kind of this package of interventions, and you work in a client-centered way to figure out what's appropriate while keeping an eye on your surveillance data. I mean, I think it's critical that you've got good surveillance data. But yeah, I mean, I think to only say we're because we don't have HIV risk, we're not talking about other problems. And absolutely, Ryan, the transmissibility of hepatitis during a needle sharing episode is 20-30% higher than with HIV. I mean, hepatitis is just much easier to transmit HIV, needle use or sexually. Hepatitis is much more transmissible, and so there's a whole other set of concerns. If we don't think about safer needles, we don't think about safer sex, we miss another opportunity. So CDC says every adult over 64 offered with opt-out language. This is really designed for primary care. This is not happening. I'm going to tell you right now, this is not happening. This guidance goes back to, probably 2010. It's been a long time, and most places outside of public health are not offering routine opt-out testing. Most of us who've been to our primary care provider have not been offered HIV testing. But again, the CDC says if we're going to find those people, we better do routine testing. And then again, routine follow-up testing is recommended for people who have any of those following ongoing risk behavior, which I look at the list. Yes, everybody I know would qualify. So that's the kind of crowd I run with. There you have it. I said earlier in the opening slide, kind of when do we conduct risk assessment? And what I said is really specific use of, I build on the motivational core skills of motivational interviewing here. Good open-ended questions about sexual health, about drug partners, sexual partners. These same core skills applied to what kinds of sex, what kind of substance use, and a conversation about the specifics of the risks that you take and risks in terms of your health. And so good use of open questions, affirmations that find strengths to build on. Reflective listening is your bread and butter anytime you're conducting assessment, sort of playing back in simpler language what you're hearing, highlighting what the most important things for your patient to hear. When I'm teaching communication skills, what I say is reflective listening is not just kind of mindless parroting, it's you triaging what's the most important thing for me to play back to this patient, what's the most important thing for them to hear themselves saying. That's the heart of good reflective listening. And then some kind of feedback. That feedback may happen based on a screening tool. You may decide a pencil and paper tool is appropriate, but however you do it, always making sure that that feedback is supportive. There's a kind of old school idea about confrontation where you get in people's face and say, you're going to get a disease, or you're going to, I really think the model here is kind of supportive confrontation. You're saying, I love the person who said most of our patients, most people say they're not ready to get pregnant, to say, well, you're not ready. You're telling me you're not ready to get pregnant, but you're not currently on a method. And just that level of I'm concerned about you and the consequences of having a baby now. You're just new to treatment, or you're just thinking about treatment, or you ain't really thinking about much treatment, but and here's your pregnancy intention. And just using my good skills to kind of offer from a place of concern. That's the difference. So the sort of old school confrontation of I'm going to prove I'm smarter than you versus a kind of empathic, I heard something you said that feels important and I want to support you in that way. And then self-disclosure, I think, can be really helpful. I'm concerned for you. You're saying you had 6 partners in the last few months. Nobody used condoms. There's a lot of cowboys out. There's a lot of cowboys out here doing a bunch of stuff. And I know you think because they're local, but they've been going to Cheyenne, or they've been going to Boise, or they've been going to Portland, or they've been going wherever. You don't know where those cowboys have been. And I'm concerned that of those 6 cowboys, we got gonorrhea here in town, and some of them cowboys have been traveling. And so what do you know about where they could have gone and their other partners? So if we talk about risk reduction counseling, the gold standard, and again, it's not something I'm saying anybody has to do, but I do think that this model, so 20-minute intervention, very focused intervention that the CDC puts forward in their HIV testing and counseling courses, they say in 20 minutes, and back in the old day, you could do an oral, collect an oral sample and stick it in the fluid, and you had 20 minutes before a result. There's now rapid. Micheline, I'm sorry, I was thinking about was cowboys culturally inappropriate. Micheline said I did okay, but if that was offensive, no offense to anybody who is a cowboy. I love a cowboy too, don't get me wrong. Thank you, Ms. White. So in this 20 minutes, you introduce yourself. Hey, we're going to talk about HIV prevention. Let me talk about your personal risks, and you go over kind of specific fluids, whatever. You work with your patient to identify a specific safer goal behavior, like what are they willing to do? And then work with that patient. What steps would you take? And I mean, I think you guys are doing this around needle use. And so it's like, well, I want to cut back on number of needle partners. In this case, you're working kind of around the dual goal. Someone's actively sharing needles, kind of the dual goal of avoiding HIV, and I would argue hepatitis at this point, that this really is an infection control plan. How many people you sharing needles with? I'm just getting away from the whole cowboy. There's a whole thing going on in the chat. I'm just not using the cowboy analogy anymore. Apparently, I've crossed the line. Anyway, what are you and your partners? I'm just going to use the term partners and not cowboys anymore. What are your partners willing to do or not willing to do? And then what steps are you willing to take? And here's a place to get clean needles. How can you get there? And so your plan is you're going to limit the number of sexual partners and only share needles with these three people. And Ms. White says these educational tools are relevant to every community and culture, even cowboys. There you have it. Thank you, Ms. White, my new best friend. I talked about PrEP earlier. I think a lot of you know about this, but I just think, again, with a lot of people we're working with, getting people to never ever share needles, never ever have unprotected sex never can seem really difficult. And so we've had in the last few years great biomedical intervention where we don't have to say never ever use condoms, where we can say you can take this one pill once a day. Truvada's been around, gosh, 3 or 4 years at least, and Descovy is recently approved by the FDA. These are once a day oral medications taken daily, nearly 99% effective at preventing HIV. Now, we're not talking about STIs or hepatitis here. This is someone who is significant risk for HIV, and consistent condom use or never ever sharing needles just isn't very likely. This opportunity offers a very high level of protection. So again, most manufacturers are going to offer some access to med. There's patient assistance. The challenge, just full disclosure, the challenge for everybody doing this work, you can get drugs, but getting support for lab follow-up labs is difficult. So just to be clear, if you're going to have this conversation, it's sort of like how if we did decide we've got enough people at risk because of their injection use, if we start a PrEP program, what would that look like, including who's going to pay for the lab to support? Truvada is kidney, nephrotoxic. There's a word you learned in school, nephrotoxic. The kidneys are vulnerable when someone's on Truvada. I don't want to over amplify that, but people are actively, physicians, healthcare providers are actively monitoring kidney function. And then, you figure out where to get drugs and where to get labs. And what some people are doing is saying, we're going to get people enrolled in health plans so that we can whatever. And there are other compounds. There are long acting, there's a real movement to get long acting the same way I get a shot every 6 months and it prevents pregnancy. The wish is that someday I can get a shot and 6 months of HIV prevention, so I don't have to remember to take it. So these are the PrEP guidelines. Again, CDC, HRSA put these forward. HIV.gov, you can find these anywhere. But again, I think when I think about these guidelines, what I'm thinking about is that more and more people think PrEP for a drug injection. And so one of the phrases I used earlier, it sounds like many of you are already there, was doing risk reduction counseling through a harm reduction lens. And so what that means is you're sort of thinking about, okay, how infectious is that fluid and how vulnerable is that route of entry? And then so that I can interrupt transmission of HIV. That's kind of the nuts and bolts. So I want people to help me out here in the chat box. If you would, again, if you've joined after we started, we're in the Zoom chat because we're having Hoovy trouble with Hoovy. So the black box down at the bottom, help me with these two patients. I want to get some harm reduction practice in before I wrap up. So we've got this patient, Stefan, sex with oral sex, anal sex, vaginal sex, multiple partner never ever uses condoms. Okay, so there's Stefan, and you say, hey, Stefan, we think it would be great for you to completely abstain from all sex. And not surprising, perhaps, Stefan says that's not an option. So the question I want your help with, those open dots on your slide, what are some harm reducing options? I'm going to put it in the chat box. Think about it. What are some potential behavioral choices, harm reducing options for Stefan that we might include in a menu of harm reducing options? What are some harm reducing options for Stefan to consider? Anybody who's willing to share those? Let's see, what do we got? Syringe programs, absolutely. Excellent idea. Condoms when you're having sex with men. Megan, that's what good use of the surveillance data says. That's not about stigma. That just means if he's having more anal sex with other men, that raises his risk back to that risk profile. What fluid, what route of entry? Semen, the most infectious fluid. Anal sex, if that's the sex he's having, highest risk. So syringe programs, testing, treatment. What other option? Catherine, absolutely. Stefan, let's talk about PrEP, brother. We're going to give you one pill once a day. You don't have to worry about cowboys, cowgirls, whoever you're having sex with. What else? Other options for Stefan to lower his potential exposure. Most of these are also going to lower his exposure, not PrEP, but the others are going to lower his exposure to hepatitis. So we're going to kill two birds with one stone. Anybody else? Other options for Stefan? I guess I could have said Stefan, I don't know. Kelsey, go on with your bad self. Kelsey Orlando gets the prize of the day. How about a take-home HIV test? Yes, take this home with you, Stefan, and do a test if you want in the privacy of your own home. All right, let's talk about my cousin Yolanda. I'm not even going to change her name. This is my cousin Yolanda. She lives out there. She's out in Boise. Yolanda's out in Boise, and she is shooting and sharing, y'all, out in Boise. Sorry, Boise people, but sorry, Idahoans, but you know what I'm talking about. So she's sharing needles, multiple sharing partners, no sterilization. She doesn't know where to get clean needles. So my cousin Yolanda, again, same question as before. Can you think of any harm reduction steps for Yolanda that she could take that would lower? I said, Yolanda, I got a drug treatment bed. You go to treatment. And she says, I ain't going to no treatment. So what options? Let's see, what do we got? Tanisha says, syringe programs. Find a star pharmacist that's going to sell clean needles. Tanisha, what I understand is if you go to the right pharmacist and you wink and you say, I've got diabetes, I need some needles, there are some friendly pharmacists going to look the other way and not make me do that. So Julie D'Alessandro, go on with your bad self. Limit number of sharing partners. Absolutely. Yolanda, could you share with fewer partners? Megan Price says, hey, what about here's a tube of bleach and a tube of water. We're going to teach you how to sterilize your needles. Absolutely. Syringe program, sterilization, limit partners. Anything else? Harm reduction steps. Jillian says, let's think about contraception and proactive. Beautiful, beautiful. If you're having sex with men, what about using contraception? Thank you, Jillian. Oh my gosh, Kelsey Orlando. I pulled Boise out of the air because my real live cousin, who's not Yolanda, does live outside of Boise. So Idaho Harm Reduction going to bring her. Come on, Yolanda. They're going to drive up and bring you your needles. Don't be a dope. So Idaho Harm Reduction. Kelsey, thank you for that recommendation. Catherine, could you snort it? Could you smoke it? Could you eat it? If we get those needles out of the way, again, I don't know how you're going to document and make your supervisor happy, but the bottom line is if she can snort it, smoke it, or drink it, or eat it, and we get that needle out of the mix, we eliminate the risk of hepatitis. I understand for a lot of people, that's a hard sell. Once they've begun injecting, going back to smoking, well, smoking not as hard maybe, going back to nasal, once you've snorted crystal or particularly had the experience of injecting, going back to inhaling it, it can be a tough sell. Maybe smoking is an easier sell. But again, if we get that needle out of the mix, you guys did awesome. Little bit of research, but that's exactly right. So when I say from a harm reduction perspective, that's exactly where I hoped you would be going, is like, hey, let's offer the perfect option. When I say harm reduction, I say, yeah, let's offer the perfect option of abstain. But for some folks, abstain is not the option. So I want to talk about hepatitis real quickly. How am I doing on time? We got 2.5 million people with hepatitis C, 850,000 people living with hepatitis, and more than half don't know they have it. 2/3 of people with hepatitis B don't have it. About half of people with hep C. So again, what I said in the introduction, how you doing in screening for hepatitis? Again, if you're not going to do it, and we know those numbers, what about thinking about collaborating with people that are doing hepatitis screening? Millennials, here's when you think about hepatitis, this is really challenging. Young people in their 20s and 30s, this is 2018 data from CDC, millennials made up 36% of new hepatitis C infections. I just think of hep C as being these baby boomers. And yes, that's true, but look at young people in their 20s and 30s. Look at Gen Xers in their late 30s up to their early 50s. And so just recognizing that my assumptions about hepatitis C, that it's an old, because I am between 50 and 70, I can say this, it's an old fart problem because I am an old fart. It's not an old fart problem. And in fact, we've got a whole bunch of people under 50 based on 2018 data. And then earlier I talked about hepatitis B and A being linked to opioid use disorder, acute hep B. What have we got? Kentucky, Tennessee, West Virginia, and then hepatitis B after years of decline, hepatitis B. So the gold standard is what are you going to do about hepatitis A and B? The gold standard is get that injection, get that dual injection. You can do A or B. So many people who are injecting, particularly if they've got any risk of homelessness or they're marginally housed, you really want to say, go ahead and get the AB vaccine. There's no argument against getting both. It's 2 shots, 6 weeks apart, 4 weeks apart. 4 weeks apart. I think it's 4 weeks apart. If anybody knows the accurate dosing, get in the chat box and correct me. But I think it's 4 weeks apart, dose 1 and dose 2 of each of the AB vaccine, the joint vaccine, and you're done. Most common STIs there you are. Oh, well, at least I don't have to worry about whatever you should have heard me say, 50,000 cases of HIV. Well, HIV doesn't have nothing to do with me. I just have sex with other people out here in Durango, Colorado. Hello. They ought to change the name of Durango to human papilloma, Colorado, because there's 80 million Americans with HPV. And so lots of HPV, lots and lots of HPV causes warts, and some people call, other potential problems. Uh-oh, Megan, I got on her people. Sorry, Megan. Except Megan's people are not going to call it HPV. So lots of HPV, mostly asymptomatic, but certainly we're concerned vaccine preventable. If you vaccinate kids for HPV, nobody's going to get it. No potential for more serious problems, including the most serious cervical cancer. It's very small percent, but people with HPV do progress to higher rates of cervical cancer. We're also talking about chlamydia, gonorrhea, and don't forget about syphilis. So in terms of health education, do you stick it up on a wall and never talk about it? Do you create 117 PowerPoint slides and read those to your patient? Here's a model for what good health education. It starts with what your patient already knows. Tell me what you've heard about HIV. Tell me what you've heard about hepatitis. Ask permission and feed a little bit in. I think part of our job is to triage what the most important thing to focus on, because people are only going to take away 1 or 2 things from any health education intervention. So if you're saying, well, you got to think about hepatitis, you got to think about pregnancy. Again, it's a potential to overwhelm people. So as you start to think about sharing what you've gotten in this workshop, maybe what you know from other workshops, kind of thinking about what's the most important 1 or 2 facts for me to share with this person. Somebody modeled for us earlier, kind of based on surveillance data. We don't have a lot of HIV, but I better worry about hepatitis. Or because I pay attention to what's going on at the county health department of the state, I know we got, what'd she say? Oh, Ryan, thank you, brother. Hepatitis A doses 6 months, 2 doses 6 months apart. B is 3 doses, first 1 to 2 months later, and 1 at first 1 to 2 months later. And Ryan, do you know about AAB vaccine, the dual vaccine? That's what I was pushing. Again, it's 2 doses, and I just can't remember how far those doses are. Ryan, you are sharp as a tack. Ryan, 6 months. Man, y'all get Ryan Jackman on speed dial. He's as smart as anybody in this RCORP family. Thank you, Ryan Jackman, for sharing your wisdom. So what I said was, what do you need to know about HIV services? The good news is most state health departments, except North Dakota, who doesn't want federal money to do this, are involved in getting some HIV and STD money. So tracking that money, figuring out what's going on. Most health departments offer HIV testing. Most have some kind of HIV care programs. Most health departments have some federal money for family planning. And so you are not in this alone, but your charge is to go out and say, who is doing family planning in our community? Where could I go to get somebody low-cost HIV care if they needed it? Jillian, they're calling you out as Ask Dr. Jackman is a wealth of knowledge. So there you have it. Jillian adds to the Ryan Jackman fan club. Good to know. I'm gonna share his name all over. Most of us have AIDS service organizations somewhere in the state, even rural and frontier states. There are a few. They are a wealth of information for you about SSPs, about HIV care, about support services. Jen's going to talk to our people in North Dakota who have never wanted federal money to do HIV or STIs. Good luck with that. But yeah, North Dakota is the only state in the union that does not take any federal money because they don't want the government in people's business. Ryan White is the federal program that administers HIV care. So the conversation is we've got an HIV positive person who just moved to town, or we found somebody who's HIV positive. They provide medical services and case management. A number of federally qualified health centers and community health centers are providing expanding HIV services. The federal government, HRSA in particular, has put out some money in the last year to increase HIV testing and HIV, including PrEP service. I think the PrEP announcement is out, like, hey, federal health centers, help us by administering PrEP. So we're seeing more HIV services within FQHCs and community health centers, which I know speaks to what's going on in the Western United States. And then housing opportunities. So SAMHSA has block grants that support early intervention. Most of you know about that. CDC directly funds all the states. I don't want to spend too much time on that. Again, as we kind of wrap up, sort of what we also need to just focus on is the impact on people who are disenfranchised, including persons who inject drugs because of access issues, because of the history of poor health outcomes. And the argument here is that we move away from just one-on-one counseling kind of interventions and look at structural approaches, getting people safely housed and educated. Wonderful resource I know most of you may know about, ruralhealthinfo.org. These last few slides I've stolen directly from ruralhealthinfo.org, which is another HRSA-funded entity. Just some other things I'm hearing about. HRSA's looking at HIV screening opportunities in MAT settings, looking at integrating hepatitis C, looking at offering where people are getting their HIV care, making sure they're being screened for opiate use disorder, more HIV testing and hepatitis testing, and hepatitis vaccine and screening in syringe programs. And so, there's some great innovation, largely funded by HRSA, some SAMHSA money to try to look at more innovative. Most of these are still pilots, so I can't say there are widespread models to look at, but there's some innovative models that look at innovation, which I think speaks to, and here's your homework. So who are the aid service providers, what FQHCs, what can your health department do for you? Print this list and take it to staff meeting. Say, hey, that good-looking bald guy from JBS, I was on a regional meeting and he did an awesome job. Here's your last homework. What are you guys doing well? And what are your next steps? I've got 3 or 4 minutes for questions. I'm going to pipe down. John, do you see any questions that I can speak to? Should we just put them in the chat?
Not seeing any questions. I think your presentation was so outstanding and comprehensive that you have filled their brains. So,
John, I got just about 4:30 next steps for our participants.
There's one more session to click on through Hoover, and that's just the wrap up for the day. If you'd like to attend that, and HRSA will be doing just a little bit about what's coming up tomorrow and talking to you a little bit and just giving you a chance to shout out where you're from. And if you want to make connections on the chat line there. So that's just the next thing to click on in your portal. And we will see you then. And Jim, thank you so very much. Time really flew. You always do a great job with that.
Great. Bye, everybody. It's been a pleasure. All the best with the rest of the meeting, everybody. I hope our paths cross again. And yeah, my name is, or my email's there in the thing, and all the RCORP TA providers know how to find me. If I can help moving forward, I'd be delighted to. But I'll keep you in my thoughts. Keep doing the good work you're doing. Keep doing the good things you're doing.
Thanks, Jim. Take care, everybody.